Well, welcome to yet another discussion of our health right here on Kirk TV, even as we mark the Kirk TV's partnership week using the hashtags Tujenge Kirk TV, I partner with Kirk TV. We are ready to start yet another conversation called or dubbed the Health Dialogue, where we will be looking at different matters as far as our health is concerned. So feel free to send in your questions and comments on our SMS and WhatsApp number. That is 0111220044. We're also coming to you live on our social media pages. Twitter is Kirk TV_Kenya, Instagram Kirk TV.Kenya, Facebook and YouTube Kirk TV Kenya. Now I'm being joined by wonderful experts on set, but just to say the sign language interpreter is Edith Koros. And on we'll just start. Dr. Karani, you will introduce yourself, then to who, then to you.
Okay.
Yes.
Thank you so much for this opportunity. My name is Victor Karani. I'm a medical officer currently based at PCH Chogoria Hospital in Tharaka Nithi County.
All right, you're welcome to the show.
Good evening.
Evening.
My name is Kamene Mwanzia. I'm a general surgeon based at PCA Kikuyu Hospital.
Good evening. My name is Dr. James Joroge Karidi. I'm a general surgeon. I also hold the position of the chief medical officer at PCA Tumutumu Hospital, and as the chief medical officer, I'm the clinical lead of all departments that give health service to the hospital, so that I can interact with different consultants, different departments, even pharmacy lab and all that, so that we can be able to secure the items that are needed, and even to strategize on the services that need to be provided at PCA Tumutumu in terms of general and even specialized and quality services. Yes.
All right. Now, Dr. Mwanzia and Dr. Karidi, you're reading from the same page as general surgeons. So, Dr. Mwanzia, when we are talking of a general surgeon, what exactly do we mean?
I think the best way to say, to explain a general surgeon is the surgeon who does a little bit of everything, more like a jack of all trades. When a general surgeon in the old days was described, he was the surgeon who did some neurosurgery, some ENT, some plastic surgery. Nowadays, a general surgeon has been classified as those who deal with abdominal and neck surgeries. But then when training, we actually do train a general surgeon from the tip of your head to your toe. Yeah.
All right. And Dr. Karani, as a medical officer, where exactly does your passion fall?
So as medical officers, we're more or less the jack of all trades in terms of everything.
Just like
but we still need to undergo more years of training to specialize in a particular field. But where we are right now, we can handle and manage most common conditions and refer them for specialized attention where the case may be. Yeah.
And just to build up on that, maybe Dr. Karedi, you can just tell us where exactly do we place the medical officer now when we are conducting, let me say, a surgery?
Actually, a medical officer is supposed, like he said, jack of all trades. Even in surgery, they are supposed to be trained to do some of the minor and even moderate surgeries, because there are people on the ground, and then if they are in trouble, then the consultants, the general surgeons, can be consulted to come in and assist. But basically, they are supposed to be trained such that they handle most of the minor procedures and even some of moderate procedures, because they are the people on the ground. Yes. When
we are talking of minor and major procedures, maybe from you, to what extent does let me say a minor surgery or a minor procedure go?
Most of minor procedures are those that we do with local anesthesia or with regional blocks, and normally they don't take more than 30 minutes. Yes.
In the major?
I always say, just to be classifying minor and major surgeries, that there's actually nothing like a small case. And so it's also always important for the patient and the patient's family to know that even in a small case, or what we call a minor case, things, complications can happen. That said, I agree with Doc where he says that minor surgery is what we usually give under local anesthesia or regional block, and major anesthesia, major cases usually would use regional anesthesia or general anesthesia.
All right. And when we are looking at conditions that would maybe lead to one being operated on or having a surgery, which one or which are these conditions that will lead to one having or to undergo a surgery, either minor or major? To you, Dr. Mwanzia.
So the easiest way for me to classify surgical cases versus medical cases, so cases that require medicine, is to say that usually surgery cases are cases that you have anatomic defects. So things that have gone wrong in the anatomy, and so you're trying to correct the anatomy. It's a bit of a global description, but I think it's the easiest way to explain it. And those that require, that are treated with medicine, are those usually what I would say are metabolic defects, things that you would actually be able to use medication to correct the defects, to correct the problem. Yeah.
All right. And Dr. Karani, I understand you have a great passion, let me say, for diabetes, and I'm sure we have cases where, let me say, things like knee replacement and such. Yeah. So, Daktari, for you, Dr. Karani, when we are looking at diabetes, let me say, and hypertension, let us just try and link them now to the two.
Okay.
Yeah.
Yeah, that's an excellent question. Currently in Kenya and even globally, but I'll focus on Kenya more. We're seeing a shift from what we used to call communicable diseases, the infectious ones, like malaria, HIV, and tuberculosis, and we're now dealing with what we call non-communicable diseases. So, for instance, in 2014, we had like 24% of all mortalities were due to non-communicable diseases, but we are now up to like 40%, approximately. 50% of all hospital admissions typically involve non-communicable diseases. 70% of patients who die in hospital die from non-communicable diseases. So to tie NCDs, which include cardiovascular diseases, diabetes, cancer, to surgery. So surgery now comes in at the advanced stages of such diseases, such as putting dialysis catheters, doing kidney transplants, open heart surgery, and valve replacement, etc. So even as a country, as we are trying to grapple with this new entity that is actually causing a lot of chaos and havoc in many households, because they're very expensive to deal with, then you can see where surgery is getting involved. Yeah, I hope that's answered your question.
Dr. Mwanzia, I've just seen you nod. What are the response that I would like, just the way he set the basis for us in terms of our non-communicable diseases, the patients or the people that you have operated on that now have these non-communicable diseases.
So I'll agree with Daktari when he makes a statement that patients that we actually do see in the surgical clinic or the surgical unit with complications as a result of untreated or poorly treated communicable diseases, patients with end-stage hypertension, with end-stage diabetes. When I'm using end-stage loosely to mean those who have not been treated well or are poorly treated. We have people who have diabetic feet. I'm sure if you walk around town now, you will not miss to see a patient with an amputation. A lot of those patients are secondary to their amputees due to poorly managed diabetes. End stage in our ophthalmology unit, because we actually do run a very large ophthalmology unit at PCA Kikuyu Hospital. A lot of the patients coming in with cataracts, a lot of patients coming in with a diabetic eye with blindness is actually secondary to uncontrolled or unmanaged diabetes and hypertension. So the rise of the non-communicable, or we call them lifestyle diseases, is actually affecting the rise in the number of surgeries that we are ending up doing in both the general unit department, the surgical department, and the orthopedic department. Yeah.
And Dr. Karidhi, having been, let me say, a surgeon for quite a number of years, looking at someone being amputated, it's not, I mean, losing your leg, it's not something that you can celebrate. It's something that needs preparations. Let us just look at amputation as a surgery, and even any other surgery that you would do. How do you prepare this particular patient before even doing the surgery?
Yes, I would say that by the time a client or a patient reaches that stage of being amputated, like she said, most of these patients, our culture is like we take time before we seek medical attention, and most of them will come when now, like she said, their stage has reached. Diseases like diabetes affect both the blood vessels and the nerves and soft tissues. So you find that by the time they come, those patients will already have the vascular system affected and the nerves, and that is why many of them, like diabetes, will get vascular disease. They get their vessels blocked, they get infection, such that when further investigations are done, like angiograms, they show that that leg cannot survive because of the stage of the disease. It goes to an extent where now that patient has to be amputated depending on the level of the disease. How much of the limb is affected, that determines the level of the amputation. It then means that the full investigations have to be done to justify that amputation has to be done. And then the patient himself has to be explained the stage of the disease and the circumstances that will occur if a drastic action like amputation will not be done. And then from there, once you explain to the patient not only the stage but post-surgery, what are you going to do, the rehabilitation that he or she has to go after that drastic surgery, and then you have to involve the relatives, the next of kins have to understand, because you are not taking only that disease away from that person, but now it becomes another issue for the care that the family is going to give. Remember, there is not only objective and subjective factors, but this is a disease that might require some economics, some finances. The relatives, once they go home, have to spend on this patient after care. They might need to have a leg bought for them. So they have to be prepared both psychologically, financially, spiritually, both the patient and the relatives, because it becomes a big task for the family once that amputation is done. And of course, health includes the spiritual aspect.
Sure.
When you have been used to walking with a leg and now you are not having it, it gives a lot of stress, even after you had been done pre-op preparation. But it comes to a reality that now I am not having this leg. So it really becomes a lot of stress, and that is where the spiritual, the emotional factors have to be taken care of. That's why you not only need maybe a counselor, but you also need a spiritual person to talk to the relatives, to the patient, so that by the time you go in, and even after, they will be able to accept what has really taken place. Yes.
And Dr. Karani, maybe how do we prevent ourselves, or if I am either a type 1 or a type 2 diabetic, how do I prevent myself from now being amputated or losing my eyesight?
Yeah, so prevention, of course, is better than cure.
True.
And one of the things that we've seen as medical officers is for most non-communicable diseases, they tend to be what we call asymptomatic in the early stages, meaning For instance, if I was even give hypertension, which is high blood pressure, as an example, from the data that the Ministry of Health has provided, almost a quarter of our population has hypertension, and half of us have never been screened. So by the time we get to the end stage or to the more serious stages of the disease, and that's when now you start getting signs and symptoms, even for diabetes when you get the diabetic food, and even for high blood pressure when it affects your limbs and you get arterial disease that might end up in an amputation. So we tend to, as medical officers and even other healthcare workers, we tend to focus more on trying to prevent, one, people from getting those diseases in the first place by identifying what we call modifiable risk factors, and then trying to reduce them or eliminate them altogether. Or if the person already has the disease, we try to prevent them from getting the complications of the disease, which is why we tell patients this is why we're giving you the medication. Yeah, so one of the most common questions we're asked in clinic is, Daktari, why am I having all these medications? Can you reduce them? Will I ever stop taking them? Because they feel, I'm feeling fine, I'm okay, why do I need all these meds? That's when we start educating them. We want to prevent you from getting to a point where you now have to go and see Dr. Karidi for an amputation. And that at that point, that's where the point goes home.
Dr. Monzia, maybe your input on the same, just before we come to you.
I think education is paramount, and education of the patient is the stepping stone to reducing the communicable diseases. Daktari was very clear in saying that you need to have patient education. One of the things that I see severally in the clinic is a patient who has come with end-stage disease, and I ask them, are you diabetic? And he says, lakini iliisha. Sorry to use another word, but he says, lakini iliisha. That they have to understand that this is a chronic problem. This is not a problem that will disappear with time, that they require continued follow-up, that the medication that they give will be lifelong, and that there are other factors that they need to put in place. They need to walk a little more, they need to reduce the fat in their diet, they need to reduce their salt. So education is the key factor in preventing and reducing the risk of getting these non-communicable diseases, both hypertension and diabetes.
And from where you sit, for, let me say, diabetes, is it reversible?
I think using the word reversible is wrong, because there are patients who are managed without medication. And those patients actually do think that because I'm not taking taking medication for this disease, then I do not have it. And so a patient who is being managed without medication, basically dietary modifications, this is a patient who you would ask to come and see you routinely, to come and check their sugars, make sure their blood markers are okay, follow up with a counselor or a dietitian, follow up with most hospitals like PCA Kiku, you do have a diabetologist, someone who can look and just follow up and make sure. Because by using the word reversible, the risk is still there. The fact that you can be able to scale down on your medications or even stop them altogether has not eliminated your risk of getting it in the future. And I think that's what happens, that a patient does take their pressure medications or their diabetic medications and their sugars are normal, or they're hypertensive and the pressures are normal, and then they say, I am healed. But then we are not belaboring the fact that it's not that the disease has been controlled, but follow-up is important. Whether or not patients' pressures are controlled does not mean that in the future things may not change. We are creatures of habit. Whatever created the habits that they are developing, so if they people who never used to walk, now when they feel better, they probably stop walking, eat the high salt food, and so the risk factors are reintroduced into their diet. So I think the best thing to say is that it's not a disease that is reversible, but a disease that can be managed. And that's very important for a patient to know.
Dr. you take?
Okay, just emphasizing what she said, because many times education is the key, because you find many times most people feel that once you are hypertensive, they've been controlled, and they have not been informed of their long-term complications. If they don't continue taking meds, they usually stop the medicine. And even so, even in diabetes, especially type 2 diabetes, once it's controlled, many people feel that they want to. They do. Many people have glucometers at home. They do and find the sugars are okay. They forget that it has been controlled, maybe by the changing lifestyles and the drugs and the treatment. So they usually stop medication without consultation. And by the time maybe they go back to what brings them back to the hospital is that stroke they have had because of hypertension, or that diabetic foot infection because of stopping drugs. So education is key, and also letting them knowing that what are the long-term complications of their diseases if they are not adherent to treatment. Yes.
All right. Thank you so much for that, and thank you for your input. So, dear viewer, we'll take a very short commercial break. When we come back, we will be talking more on matters health, even as we look at or just focus on non-communicable diseases, as we've done on the first part. Also looking at surgeries from the PCEA Kikuyu Hospital, as well as Togoria and Tumutumu Hospital. Continue sharing your comments and questions using our SMS and WhatsApp number. That is 011220044. We will be back after this break.
Five people, five things for Kirk TV. This partnership week, we urge you, our viewer, to set aside 5 minutes to do the following. Ask 5 people to pray for Kirk TV. Request 5 people to tell 5 people about Kirk TV. Encourage 5 new people to watch our amazing programs. Ask 5 people to partner with Kirk TV for whatever amount and make a monthly commitment. And guide 5 people to like, follow, and subscribe on Kirk TV social media pages. 5 minutes, 5 people, 5 things for Kirk TV. Pamoja tujenge Kirk TV.
PCEA Ongata Booth Girls High School of Excellence is a modern private girls boarding school offering the 844 curriculum. Our vision is to provide an education that focuses on the holistic growth and development of each learner who will be readily admitted to world-class institutions of higher learning, graduating into exceptional students of integrity.
Our school will not only offer academics, but we also have extracurricular activities. For example, we have swimming pool, and it's not only a swimming pool, but it is an Olympic standard swimming pool whereby our students are able to feed their mind and build their mind.
We take care of our girls spiritually. We have a church just across here where they worship every Sunday, and in between the week we have a very, very strong Christian union. We really encourage you to bring your children here that they may get the experience of learning in a Christian environment.
We also have teachers who are well skilled and trained and also friendly. They teach us to be disciplined, which goes hand in hand with academics. PCEA Ongata Booth Girls High School of Excellence is the place to be.
Our school is founded on Christian background, and we are surely assuring you that when you bring your girl, you will not regret.
We have vacancies in Form 1 and 2 available for application. You can apply now.
Pay for your tithes and offerings, PAP, using Family Bank's USSD solution for church collection. KanisaPap. All you have to do is register and pay. To register, dial code *325 *5 hash. Accept the terms and conditions. Enter your first and second name. Then your church's 4-digit code and church name. Confirm your registration and you're ready to contribute. To contribute, dial *325 *5 hash. Select your type of offering. Enter the amount you want to contribute. Once done, confirm the amount. You'll get an M-Pesa PIN prompt. Enter your PIN and you're done. You will receive an SMS confirmation from Family Bank. Isn't that easy? Try KanisaPap today.
Well, welcome back. This is the Health Dialogue, where we are discussing, or I'm engaging different experts from the PCA's 3 health facilities. That's PCEA Chogoria Hospital, PCEA Kikuyu Hospital, as well as PCEA Tumutumu Hospital. And just to read a few of your comments, that's on our Facebook page. Remember, you can follow the discussion on our Facebook and YouTube page, where we are live at Kirk TV Kenya. Daniel Deritu says, you are following. Good to see the experts, especially my old good friend Dr. Karidhi from Tumutumu Hospital. Daktari Daniel Karidhi says hi to you, and keep on sending in your comments as well as questions, and the experts in the room will be glad and happy to respond to them. And now to Dr. Karani, we've talked of how important let me say patient education is. I just want us to look at the universal health coverage. Do you think the aspect of public health has been incorporated in the universal health coverage?
Okay, so universal health coverage,
yes,
refers to that system where we get affordable, quality, essential health care as per the Bill of Rights in the Constitution. It's part of the SDGs and for the United Nations and the WHO, and even part of our strategic plan. While we have noticed, as part of the healthcare workers, we have noticed great strides that have been made by the government, both in terms of especially the 3 essential pillars of that UHC, which includes service delivery, health financing, and governance. But there's still room for improvement. So to answer your question specifically for public health education, it's the government has really tried in terms of promoting guidelines that that healthcare workers can use in terms to get the information to educate patients. They've organized for trainings so that healthcare workers can be competent and efficient in terms of how they deliver their services, and also how they educate patients on the various diseases that they have. But there's always room for improvement, not just in the public health aspect of it, but also in terms of the financing, in terms of handling the human resource. So there's always room for improvement. Yes.
All right, and Dr. Mwanzia, as working in a mission hospital, would you say you have felt the impact of UHC from where you sit?
I'd like to start by saying Rome was not built in a day. However, seeing the impact of the universal healthcare in a mission hospital, I have actually felt it. I'll explain this in a very simple method, that the patient who has little now can be able to have much more done for them. Is it possible to do everything and fix everything in one go? No. But are we able to do more? For sure, I will say yes. Because patients who have access to more affordable healthcare are seen earlier. They seem to have better outcomes than patients who are seen late and then have poorer outcomes. Yeah.
Okay, and Dr. Karidhi, for NHIF, let me talk of both the minor and major surgeries that your facility offers. What surgeries does NHIF cover fully, and which ones does NHIF cover maybe partially?
One very important partnership that the NHIF has done with faith-based institutions is to provide what is called comprehensive coverage. Comprehensive coverage means whether it is a minor surgery, whether it's a moderate surgery or a major surgery, it's covered by the package that the NHIF gives. And that is why now when you look at what they said on universal healthcare, affordability, when a person does not pay for any cost of healthcare, what they are asked to pay is just an annual fee of 6,000, such that they are now covered comprehensively for both surgical and medical cases. That makes it very easy for their minor surgical procedures as well as moderate and major surgical procedures to be covered. So in terms of that partnership, if enhanced very logically, many people are able to pay for their NHIF, means that they will get complete quality health care without undergoing any extra cost. Yes.
Karani, would you say the same in terms of NHIF, yeah? Because as a journalist, I have done a number of stories of on non-communicable diseases, and patients are always complaining, especially, let me say, for dialysis, after NHIF reduce let me say, the cover for that particular service. Would you say the same applies for patients living with non-communicable diseases, or why are they always complaining that NHIF this and NHIF that?
Okay, so that's a good question. I think that's one of the things that universal health coverage is trying to solve in terms of health financing. You find that in Kenya, when you look at the health expenditure from a government perspective, every 100 shillings of health expenditure that is used, 30 shillings is contributed by the person who's seeking healthcare, and without that they can't get. And when you extrapolate that, you find that it's a lot of money, such that even up to 7 million people can't afford healthcare. Having a national health insurance fund like in NHIF has led to more people seeking health services so that they can get the treatment that they need. In very many instances, it covers for very many tests, it covers for drugs, certain drugs. It also covers for surgeries as well, both minor and major. So, well, there are always hiccups between when you have a huge fund like NHIF. It's mainly been positive. It has helped save very many lives and prevent premature deaths, which is one of the goals that the country and the world has in terms of SDGs. Yeah, so
all right, thank you.
I would advocate for everyone to get an NHIF cover as soon as possible. Yeah.
Thank you so much for all your input on that. We'll just switch gears a little bit and look at let me say, technology and medicine. And Dr. Monzia, we've all heard, or a number of us have heard of telemedicine here and there, especially during the COVID-19 era in the, let me say, developed countries. Just let us know, what is telemedicine?
Telemedicine basically is seeking healthcare without being physically in the same room or in the same vicinity as the practitioner providing the medicine. An easy way to put it is either through a WhatsApp video call or a WhatsApp call or a Zoom call, where you and the practitioner are actually engaging in a health in a health conversation, usually from a need that has arisen from the patient. It has actually has come up during the COVID period, and a lot of hospitals have offered telemedicine as an alternative to coming physically to the hospital to be seen. It does have its downsides, especially in the fields that me and Dr. Karevi are in, because physical exam is now eliminated from a patient, from the practitioner. And we always say a part of a holistic exam is a good history and a good physical examination. So once you eliminate the physical examination, there are some gaps, there are some hiccups that can occur. It is a very good way to follow up a patient who otherwise does not need a proper physical exam, a patient who basically is being managed for chronic disease, because by then the history is more important. So there is a role and there is a function for it. I'm very careful to say that it cannot be everything, because there always is a place for the doctor and the patient to be physically present in the same room. I'll give a good example, and Dr. Ari will reiterate. If there sometimes a patient just walks into the room and you can actually see what is wrong with them. And so that eyesight, what you can see with your eyes versus what you can see across a screen, are two completely different things. And it's also always be careful by having conversations with patients over the phone, because that's where sometimes the mistakes are made.
Yeah, thank you so much. Dr. Ari, you can just add on that. And do you think as a country we can embrace such technology in terms of just linking now technology and medicine?
I think the Ministry of Health has been having those plans of having telemedicine introduced, especially in public hospitals, and this also applied especially in surgical procedures, where in theater, by video, a consultant can consult a senior consultant, and the senior consultant can give directions on the steps to perform that surgery, especially when they are stuck. You know, it's also used a lot in imaging. You find a lot of images are taken even in rural hospitals, but they are communicated to a radiologist in Nairobi or elsewhere, and they are able to see the images and send the reports. So it's really working, and I think the government is working to have such introduced. Yes, because even in surgical procedures is being done. Yes.
All right. Dr. Monzia, have you been in a situation where, as Dr. puts it, where you are consulted, let me say either via call, and there is a surgery that is going on, and you're consulted to actually help this other doctor go through the process? So,
as I'm sure you're very well aware, in the country, the distribution of healthcare is very pulled towards the towns, especially specialist healthcare. So I have gotten a couple of calls from former interns, so medical officers, who have been posted to areas that are a little bit far from a specialist, and the medical officer has called and asked for advice and guidance. I will be lucky, and I'll be lucky to say that all the patients that I have been consulted have been able to have enough first aid to make it to the second point of meet, or this a higher level hospital, to get continued health care. And also I've been also lucky to say that I'm lucky to say that it's because there was a good communication between me and the medical officer. Usually it's a medical officer who has called for help. One thing I also want to say is, because of the pooling of health resources towards the cities, so if let's pick a place like Tharaka Nithi, the healthcare is very near the towns and very sparse. So it's usually a medical officer who's ending up in the periphery. Then access towards transportation usually helps the patient get to the hospital fast enough to get helped. Yeah.
And Dr. Karani, from where you sit, what's your view in terms of telemedicine, maybe the positive side and the negative side. Dr. Mwanzia keeps on referring to the medical officers.
Yeah, the people on the ground.
Yeah.
So telemedicine and in fact technology, we've started seeing interesting trends in medicine, especially in terms of mental health. Now during the COVID pandemic, when there was a lockdown and people couldn't move, and we had spikes of depression and suicidal ideation, we've seen therapists, psychologists, and even psychiatrists have sessions with patients online, which is a plus. We have tumor boards where patients are discussed among experts. Sometimes even those experts are not even in the country, they're elsewhere, and they are able to come up with a decision that helps patients with critical decisions that help patient care. So while the penetration has not been as expected in rural areas due to certain challenges, we can only expect that to increase, especially as smartphone penetrance continues increasing. And even as a whole, overarching, when you look at technology, we're now moving even in medicine from that paternalistic aspect of medicine where the doctor would be the one to tell you this is the way to go, this is what to do, to more of a partnership. Because now the patients that we're seeing, even in faith-based hospitals like Chogoria, we find shoshos and gukas who already know something about their disease and they have questions. So those are interesting trends, and they'll only become bigger as time goes on. Yeah.
And what would you say is the biggest challenge in Kenya's health sector or Kenya's health system right now?
That's a challenging question. So there are multiple challenges, but as we've noted, Rome was not built in a day, and we are making strides in some, but we always have room to improve. When you look at health financing as one of the pillars of healthcare, when we look at the budget, the amount of money that is set aside for healthcare every year, usually between 4 to 7% of the total. But when you look at the commitments that Kenya itself has made in terms of policy, like the Kenya Health Strategic Framework (ETC) and the Abuja Declaration of 2001, we're supposed to be setting aside around 12 to 15%. So that's something that we have room for improvement. When you look at service delivery, we have improved in terms of facilities, and even specialists are increasing, but there's always room to improve on how we organize how that labor will be spent or distributed in the country. We have room for improvement in terms of how we train. We need more training, we need more specialists so that they can move away from the urban areas to the rural areas, so as to prevent calls from medical officers to consultants in Nairobi. Yeah.
Okay.
So there's so many challenges, I'm sure.
You can still share some of the challenges from where you are.
I think also, just to add on it, one of the challenges we are actually facing is adequate access to good health care. If you I'll give a good example, that when I see patients in our clinic, one of the big things that they say is that we had been sent for an MRI, however we couldn't afford it and we don't have an HIF. And that MRI is standing between them and the diagnosis. And for them to get an HIF, I think it's a 3-month waiting period from the time they fill it in. So there's always this delay in treatment, and delays in treatment seems to be a big issue in the hospital.
I think a good partnership between the insurances and patients or the community can enhance those challenges in health provision. Because like what Dr. said, many of them you find that they don't have health insurance, and they are not financially they are not able, so that hinders them from seeking immediate health service or treatment. The other thing is also promoting primary health care, especially if in terms of having infrastructure like dispensaries and health centers that have trained personnel, that have drugs that can be able to take care of the challenges that are there in the country. And again, partnership of the government, the insurances, with faith-based institutions, because you find that most of the faith-based institutions are in the rural setting, and that is where most sick and poor people are. So if there can be good promotion of good partnership between the public sector and the faith-based institutions, in terms of sometimes provision of maybe equipment, provision maybe of some staff, some personnel and specialties, that would really help in handling some of these health problems that we have. Because most of the faith-based institutions depend on the income they make from the patient. So you find they also have handles in giving free services of very low cost services to the communities they serve. So if there can be good partnership between the public sector, the government, and the insurances with faith-based, I think that can go a long way in handling most of those challenges that people have. Yes.
All right, thank you for that. And I'll just read a few comments. There is someone here saying that just appreciating what mission hospitals do. He says mission hospitals are the best, and any of us can respond to this. He says, hi Kirk TV, please doctors, please teach me on asthma management. It has troubled me a lot. Please, I need your help. We go to the medical officer.
Yeah, so that's a good highlight of how telemedicine sometimes can't, or technology can't bridge the bond that exists between a doctor and a patient. Because for such cases, you need to actually go and talk with them, get a good history, get an exam, do a physical exam, so as to know that one is actually dealing with asthma and not something else. And then after that, we'll start seeing how well they are controlled, if they're on any medication, what their triggers are. Yeah, so for such, when we get such consultations, we usually advise patients to come and see us in hospital, not because we want to inconvenience them, but because we know that we're going to get more information on a one-to-one interaction that will be beneficial to them. Yeah.
All right, thank you so much for that. Anything to add on the same?
I think the question was very general about teach me on asthma, and it sounds like it's a patient who's suffering from asthma or has a relative suffering from asthma, so we're not actually too sure what we're talking about. I know that from my old knowledge, and I could be quite wrong, that usually asthma peaks in two phases in life. So the first phase is usually children up to 5 years of age, and then it starts to fade away, and then we start to get it again in older life. And even how we manage them will be very determined on what type of asthma we're dealing with. As Dr. Tari has said very clearly, we're talking about what are the triggers. Is it exercise? Is it anxiety? Is it dust? We have no clue, having not had a conversation with this patient. And another thing for a patient also to understand that actually asthma is classified as a chronic disease, and so this is a patient who would require continued follow-up, not seen once in the casualty or in the outpatient department and given medication, and not a patient, and then doesn't follow up. This patient must come back to be seen. Yeah.
All right. And it seems like Tumutumu Hospital, you have quite some fans. There is someone saying great transformation for PCEA Tumutumu Hospital since the induction of the new administrator, that is just appreciating Mr. Hudson Kenya. So we'll take another very short break. So when we come back, we'll just be discussing of what exactly maybe Chogoria Hospital, Kikuyu Hospital and Tumutumu Hospital, from where you sit, what exactly maybe is happening in the surgery, what exactly is happening as far as non-communicable diseases are concerned. So dear viewer, keep on sending in your comments and questions on our SMS number, which is still our WhatsApp number, that is 01112200044. Remember, we are still coming live on our Facebook and YouTube channel, that is Kirk TV Kenya. Twitter is Kirk TV_Kenya. Instagram KirkTV.Kenya. Keep tuned in to Kirk TV. We'll be right back after this short break.
Since family means no one is left out, join me, Faith Kaulu, on Family Saturday, where everyone will have something. Remember, family is not only important, it's everything. So let's do this together. Five minutes, 5 people, 5 things for Kirk TV. This partnership week, we urge you, our viewer, to set aside 5 minutes to do the following. Ask 5 people to pray for Kirk TV, request 5 people to tell 5 people about Kirk TV, encourage 5 new people to watch our amazing programs, ask 5 people to partner with Kirk TV for whatever amount and make a monthly commitment, and guide 5 people to like, follow and subscribe on Kirk TV social media pages. 5 minutes, 5 people, 5 things for Kirk TV. Pamoja tujenge Kirk TV.
Well, thank you so much for staying tuned to Kirk TV. Remember, this is the Kirk TV Partnership Week. Actually, it is the second day, and today we have been discussing matters health from morning until now. And I have guests or experts from PCA Tumutumu Hospital, PCA Chogoria Hospital, and PCA Kikuyu Hospital. It is the health dialogue. We've tackled quite a number of issues, and if you're just joining us, you can still go back to our social media pages and start the conversation from where we started it from. Remember, you can use the hashtags Tujenge Kirk TV and partner with Kirk TV on all our social media pages. You can also send in your comments and questions on our SMS, which is also our WhatsApp number. There is 011220044. Now, Dr. Mwanzia, we were just looking at, during the break, we just had a small chat about misdiagnosis of a patient or people. Just paint a picture for us, and why does this happen?
So, just to make everything clear for the audience, what is misdiagnosis? I would say that misdiagnosis is getting either the wrong diagnosis or an inadequate diagnosis. By an inadequate diagnosis, I would be saying a patient who has a condition that has not been completely diagnosed. And so those are the two things that a misdiagnosis covers. Why does it happen? It happens due to several reasons, and I'll say My biggest quote is that to err is human, and who are doctors and who are medics, we are all human, and that's the paramount reason most of the time misdiagnosis happens. At what level does the misdiagnosis happen? It can happen at several levels. As I had said earlier, a patient is a whole. And for you to come up with a diagnosis, you must go through a series of steps. So the first step is a history. So what the patient tells you. So if you come and tell me that you have a cough, then you lead me in a direction. If you tell me your knee is hurting, you lead me in a direction. Sometimes the misdiagnosis happens at history taking because of fear or the fact that you feel embarrassed about a condition, then you eliminate some of essential history, and so someone misses the diagnosis at that point. The second time it can happen is during the physical exam. So when you are examining this patient from head to toe, then there are salient signs that could be missed either by the physician or the clinician taking care of the patient, or by the patient themselves. There are several times when a patient says, I'm not comfortable with you examining me in this way. And so there, at that point, a diagnosis can be missed. The third time it can happen is during the investigation. So I have an impression. That you have a problem with your chest, and so that's what leads me to the chest. And then the scan is done, and the scan is either inadequate or the wrong scan has been taken, and so things are missed. And at that point, we miss or make an impression that was not what we wanted to take at that point. And then the last thing is a misdiagnosis can happen when conditions are closely related. So I may have asthma and bronchitis. That's a simple one because we were talking about asthma. They are quite similar. And so the small criteria that you would use to separate one from another are not quite clear. And so at that point, you could have a misdiagnosis. Yeah.
And Dr. Karidhi, being a surgeon, have you been in a position where someone has, or a patient was referred to you that had undergone wrong surgery for you to correct?
Yes, there has been. Like I alluded earlier, investigations are very crucial, especially imaging, like she said. For superficial lesions, misdiagnosis might not happen. For deep lesions, especially when they are intracavitary, in the chest, in the abdomen, and you find the imagings are done and they don't give the correct diagnosis. We usually say surgery is the ultimate weapon in giving the definitive diagnosis, especially in those cavital lesions. So sometimes you might find that an imaging was done in a patient who had a lesion in the abdomen and was diagnosed to be maybe a gynec while it was a surgical, or it was diagnosed to be a moderate procedure, maybe an appendix, while it was a tumor in that region. So sometimes you find that those patients are opened up maybe by a junior doctor, and when they are not able to collect the disease, then that patient is referred, we are able to operate them and do the necessary. So it can happen, especially when the imaging is wrong and a doctor goes in and is not a specialist in that area. Could it be a surgeon who went in and found that it's a gynec case and would want the gynec case to handle? So that patient is referred so that that specialist can be able to handle. So if misdiagnosis is done, especially in those deep lesions, mistakes occur, especially when they are done by maybe junior doctors. So yes, yes, and when the imaging is not correct, yes.
And I want to fully agree with Dr. Mwanzia that there are symptoms or there are conditions where symptoms might be similar, but Dr. Karani, this would happen or has happened a number of times, where especially misdiagnosis of cancer, yeah? With your passion, let me say, for non-communicable diseases again, why would you say there are quite a number of misdiagnoses as far as cancer is concerned?
Wow, that's an excellent question. But the way my senior colleague explained, sometimes even with cancer, some conditions like cancer, most non-communicable diseases, of which cancer is a part, they tend to be asymptomatic in the beginning. So you would find even something like breast cancer would be painless. You know, you'd have a lump and then you'd go to the junior doctor and it's like, this is a lump, we'll come back and see you in a few months. And by the time you're coming back, the disease has progressed and now there are signs and symptoms that are screaming that this is breast cancer. And at that point, that's when the clinician says, this is bad, you need to be treated. Which is why when you look at part of the country's preparation for tackling with non-communicable diseases, we have a policy for screening. So we're trying to educate all healthcare workers to be able to know that this patient has this and this risk factors. We should be screening them for breast cancer, for prostate cancer, for cervical cancer, etc. Yeah, so there are efforts that are being geared towards reducing the rates of misdiagnosis, both in terms of education and screening, and also allowing healthcare workers to have the facilities and the equipment they need to detect these diseases early on when they are largely asymptomatic, but that's the time when they can be treated effectively. For instance, something like cervical cancer. It's actually leading in terms of mortality for women, but early screening can get it early, it can be cured. Yeah.
Thank you for that. I'll go ahead and read a number of comments that's on our WhatsApp. From Anne Joroge, she says she's following a good discussion. We should have more of this health dialogue. Thank you so much, Anne, for watching. Again, there is one more here. Ongera to our very own doctors. Still saying hi to Dr. Karidhi. And another one for Dr. Karidhi. I just wanted to express my deep gratitude for the dedicated work you do day after day. Dr. Karidhi, you mentored me in surgery and especially theater procedures. It's still an asthma question. I am 35 years of age. It all began as allergy and developed gradually to asthma in the year 2020, and I see it worsening day in, day out. Just a comment still, Dr. Karali?
Yeah, so I would add that 35-year-old to, if they are near Tharaka-Nithi, come to PCH Ogoria. We have clinics Monday to Friday, medicine, outpatient clinic. We will have a physician, a specialist clinic, where we'll be able to sort that out. Yeah.
All right, thank you so much for that. Now let us just discuss different services that we are offering in our specific health facilities, and we'll start with you, Dr. Monzia, from your department. Just share with our audience what exactly is happening there.
So thank you for that question. So as PCA Kikuyu Hospital, we are, I think, one of the older hospitals. We actually are divided into 3 units. And it's also, I always like to say it because patients do get confused when they come to PCA Kikuyu Hospital. So there's the eye unit or the eye department, then there's the general unit, which I'm located in, and then there's the orthopedic and rehabilitation unit. Now, as far as the hospital is concerned, each unit works independently, but they also work together. So you do not have to only come to one unit and, if you have multiple problems, not get seen in all the 3 units. But it's also important just to say that we have classified the hospital into the 3 units. As far as the general unit, as you can tell, I have not mentioned everything. So I work in the surgical unit. I am a general surgeon. But then there are a lot of other surgeons who work with me. There is an ENT surgeon, an ear, nose, throat doctor. There is a neurosurgeon. There is a maxillofacial surgeon who runs the dental department. And there is an obstetric and gynecology department which also runs within the hospital. As part of the hospital, what are we doing that's new and exciting? We are training, and we're training residents to become surgeons. So there is a program called COSEXA, which is the College of Surgeons of Eastern, Central and Southern Africa, of which we are part of. And we are very excited to get young orthopedic surgeons in the department. Another thing that is quite exciting is that we're actually trying to grow our renal unit. And so we actually do have a nice new dialysis unit, very beautiful, very comfy chairs. So I'm sure those who had come to the hospital before had a slightly older unit. And so we are spending a lot of time investing in dialysis and chronic healthcare management. There is accessory services, I won't call them, they are surgical services, not surgical services, they are medical services that I have not mentioned. So we do have physicians, cardiologist and a general physician and a diabetologist who comes to the hospital. And we also have a psychologist, because mental health has become very important and we have forgotten about it. So we do have we have a psychologist who is in the hospital with working along with several counselors to manage our mental health. Yes.
All right, Dr. Karidhi, what exactly is happening at
PCA
Tumutumu?
Tumutumu Hospital is a level 5 hospital. And being level 5 hospital means that we are a referral hospital. Apart from the general care that is done in other departments like medical, pediatrics, we do many operations. We have 2 neurosurgeons in the vicinity. Since November 2020, when we launched our ICU and HDU unit, so we give critical care services. We have seen many brain tumors being operated in our hospital by the neurosurgeons. Among the many services that we have introduced, we have an orthopedic surgeon who does both clinic and surgeries every week. We have a plastic surgeon who consults when we have plastic surgery to be done. We have a gynecologist, incidentally. PCA Tumutumu Hospital is a hospital who has enhanced its gynec laparoscopic surgery. We have a gynec who has promoted what is called laparoscopic machinery, taking it to so many rural areas. So almost 90-95% of our gynec cases are laparoscopic surgeries, which makes the period of stay, the surgery shorter, the period of stay in the hospital shorter, recovery shorter, and post-op outcomes better. We also have ENT. We do all ENT procedures, both clinic and surgeries. I do most of the general surgery. We have a urologist who does urology surgeries. And dialysis, like she said, we have a dialysis unit. We have a 7-bed dialysis unit, which is active with a consulting nephrologist who comes monthly to see those patients. Currently, we are introducing a new outpatient complex, which is going to have an emergency and accident unit with specialized clinics, with general clinics, with an emergency ward where acute trauma and accident and emergency will be admitted. We are going to have a theater in the same outpatient, so that when there are trauma patients who need immediate care, they don't have to wait to go to the main operating theater. So it's going to be one of the modern complex outpatient complex that we are going to have, that is going to provide all services that are required in outpatient. This Saturday of 30th, we are conducting a free medical camp, mostly targeting on screening for diabetes, hypertension, CA cervix, CA breast, on oral health, that is the dental services, the eyes. So we provide also ophthalmology services and dental services. And on this Saturday we are going to do a screening for those 6 conditions. Yes, and then action will be taken accordingly. Those that have hypertension or diabetes, they will be advised accordingly and treated. Those with CA cervix, especially early cervix, will be given, especially in cervical cancer. We have a thermal abrasion, so they will be treated at that point of diagnosis. Those with eyes, they will be advised accordingly for eye surgeries and maybe glasses. So those are the services we are providing. Of course, we have a training school, which we call it PCA Tumutumu Training College, because it doesn't only give training on medical courses, nursing courses, perioperative courses, but also we give training on IT, we give on nutrition and dietetics, and we also have business training. So it's incorporating all other trainings. That's why now we are calling it PCA Tumutumu Training College. We are planning to, because we have a well-established critical care, we are planning to start critical care training for higher diploma for nurses as per next year in March. Nursing Council has come and done the necessary inspection. So by next year, most likely we shall start training higher diploma for nurses in critical care.
All right. Thank you so much for that. Now we have only 8 minutes and people are really sending in questions and comments, but I'll give you a chance, Dr. Karani, just to share more about PCA Chogoria Hospital.
Okay. So in 100+ years of existence, PCA Chogoria motto is health for the family. And we are offering a multidisciplinary approach to some of the things that we've already talked about, and can give you, it's more of a snapshot of what the country is trying to do in terms of healthcare. So we've been known largely for our surgical prowess, because we have a wide array of surgical services, but we have recently expanded that to be also able to offer certain specialized services in terms of kidney health. That includes AV fistulas, and soon we are going to be offering kidney transplant services. We also have a modern dialysis unit. We have visiting specialists like neurosurgeons, orthopedic surgeons, who also do specialized operations, which means that in our area, all the patients that are referred to us get comprehensive care, and they don't have to go to the big centers in Nairobi. That said and done, we also have, we are big on family medicine, because we also have a training for family medicine physicians. We have one for surgeons as well. We have clinics that run from Monday to Friday, both specialized and both general, from the medical outpatient clinic to the gynecology outpatient clinic, the surgery one. So we are able to see quite a number of conditions and deal with them in-house, meaning that we can intervene at all stages of the disease process, both from preventive to preventing complications and to managing them as and when they occur. In addition to the training that we offer for family medicine, for surgeons and for nurses, we're also looking forward to training more internal medicine physicians in the future. We have a number of community outreaches, because we've noticed that some patients don't come to us, so we are going to them. And that's something that we'll be focusing more in the future. We also have more advanced imaging services. For instance, we have a newly established MRI and a CT scan. And we also offer echocardiography services. All those that we're talking about, all those services are geared towards that multidisciplinary action, care that we are big on. Yeah.
Okay, I'll just ask, let me say 3. Hello Kirk TV, this is a great initiative of equipping the community with knowledge. Thank you so much. Keep doing the good work, Dr. Mwanzia. We are proud of you, always full of knowledge and willing to teach. Shalom. Someone else is sharing of her experience, her misdiagnosis experience. She says she's watching from Embu. I was misdiagnosed with fibroids, went to theatre only for the doctor to tell me that she did not have fibroids and her uterus was removed. So Dr. Manzia, just briefly, with such cases, who is to blame and how do you correct such?
I think usually pointing a finger is the most difficult because we also don't have the full story. So I'll be very clear that at this point I cannot be able to point a finger to who has made the misdiagnosis. What probably has happened is that the surgeon has opened and has found that things are much worse than they're expected. And I'll like to say that the radiology imaging is a good thing, but imaging is not God, in the sense that something may look dark and so give you an impression of a fibroid, but actually it was not a fibroid and it was a cancer. And so the imaging is a guide, but it is not God. It cannot tell you everything that is going on. My advice, in as much as this patient is going, is if they have concerns about it, is to follow up with the physicians to find out where the gaps are. As most hospitals, and doctors will tell you, most hospitals actually do run something called a morbidity and mortality meeting, where we sit down and we discuss gaps in knowledge. Where was a gap felt? We saw this patient, X happened, we didn't want X to happen, Y happened. Why did Y happen and not X? In a case like that, then the hospital will sit down and discuss at what point could we have made a change, and if we could have made a change, or what steps can we take next time
to avoid such
things.
Thank you so much, Dr. Monzia. And another one, Dr. Karidhi, you'll respond to this, but very briefly. We only have 2 minutes, but we have to respond to her. Kindly explain how to take care of an organ failure patient at home.
Well, you see, organ failure depends on which organ. Because it could be a diabetic patient with kidney failure, but most of the organ failure, it could be a respiratory patient, a patient who has respiratory distress. It's failing, really will not be taken care of at home, because unless they are with a ventilator at home, so it's very difficult to really say you can take care of an organ failure at home, because most of them will need care at a hospital setting, because most of the organs that fail are either the kidney or the heart or the lungs, and the liver. By the time they go to liver failures and the pancreas, they will already be going to multi-organ failure. So it's very difficult to say that you can be able to take care of an organ failure at home. It all depends on which organ and to what extent. Yes.
Or let's say a heart failure.
A heart failure, when you have a heart failure, it means that you have to be keen on taking your medicine as advised, and seeking for assistance as much as is needed from the doctor treating you. Like we said, we already have telemedicine, which you can do that. Of course, they might need oxygen at home, which they can be able to get. But heart failure, being the way it is, the best thing is to, if it has gone to an extent where you need oxygen supplement, the best thing is to be at the hospital. But if you have not gone to that extent, the best thing is to be compliant with the medicine that you have been given. Yes.
All right.
And to seek consultation as necessary.
Okay.
Yes.
Thank you so much, Dr. Karidhi. Thank you, Dr. Mwanzia. Thank you so much, Dr. Karani. It's been quite an informative session, I have to say, because as a host, I've also learned a lot on the same. Thank you so much for your time. And from where I come from, Uko Western, now when you go to your respective hospitals, yeah, tumesalamu za Kirk TV kabisa kabisa, and ask them to partner with Kirk TV. Well, thank you so much, dear viewer, for tuning in and keeping me company from morning, that is from actually 6:30 until right now. Thank you so much for sending in your comments. Thank you for sending in your questions. And thank you to each and every expert that was able to come into the show and share their expertise or just share with our audience on matters health. Thank you to each and every person that made each and every show a success, including my technical people right behind the cameras, led by Joseph Kalunda. Thank you so much to the director of Kirk TV, that is Reverend Bae, and thank you even to the administration and the head of Kirk TV, that is Eliud Kagema, as well as my fellow presenters for the support that you gave me today. Until next time, or until tomorrow, where Vincent Kerosi will be joining you on Matters Business, I'm wishing you a lovely and blessed night. As always, your health matters, and I'm wishing you a healthy week ahead.